This video shows the technique of hypospadias repair in a child who has undergone previous circumcision. This was a 2-year-old boy who had undergone ritual circumcision by the traditional technique using a straight razor. Very little foreskin was left, and he had a mid-penile hypospadias without significant chordae. So, an onlay type of Matthew procedure was planned, and a U-shaped incision on the ventral surface has outlined the onlay flap. 1:400,000 lignocaine with adrenaline was infiltrated into the tissues to stop oozing. Here the flap has been detached from its proximal limit together with the underlying subcutaneous tissue and has been elevated up to the urethral meatus. The meatus itself was of adequate size and did not require a meatotomy. This shows the creation of the urethral plate, which will finally accept the onlay flap. The patient had a fairly wide urethral plate with a reasonably deep glandular groove. Therefore, it was possible to cut right along the margins of the glandular groove to get an approximately 3 mm wide strip to accept the onlay flap. So here, retraction of the tissues from both sides gives a good idea of the width of the urethral plate. In keeping with the Snodgrass principle, the meatus was planned at the mid-glans level rather than at the very tip, and therefore the parallel incisions outlining the urethral plate were only carried up to the proximal glans level initially, in order to avoid going too far distally into the glans. We then also cut the skin along the Furlit's collar till 1/3 of the way around the circumference of the left side of the glans in order to provide later skin cover over the repair. This skin flap was detached from the underlying corpora cavernosa, taking the subcutaneous tissue together with it. So at the end of the dissection, we have got a Matthew flap, Matthew onlay type of flap, ready to be sutured to the underlying urethral plate. We have got subcutaneous tissue and skin cover for the repair, and suturing can now begin. This was started at the meatus end using 6-0 Vicryl suture in a continuous interlocking stitch. The suture was inserted subcuticularly without including the skin margins. So as we progress along the continuous suture line and come to the end of the point where we had cut the urethral plate, it is necessary to elongate the cut a little further, taking the position of the meatus up to the midpoint of the glans, and then the continuous suture line is progressed further. I generally prefer to take the continuous suture line almost to the end of the position where the meatus has been designated, and then do a couple of interrupted sutures to approximate the urethral plate with the onlay flap. But of course, the suture line can be taken to the end in a continuous manner as well. It's just, I think, a matter of personal preference. So a tiny cut more to advance the meatus to its final position, and one stitch later the continuous suture line will be tied off, and a couple of interrupted stitches used to complete the left hand side suture line. And this is the first of the interrupted sutures going in. So having completed the left hand side suture line, we now move to the right hand approximation of the urethral plate and the overlying flap, and the incision demarcating the urethral plate is brought up to a point parallel to the left hand position, and this prevents lateral obliquity of the meatus. The urethral plate is released from the underlying glans tissue, and the right hand continuous suture line started. While doing a subcuticular stitch, it is important to get a reasonably thick bite of the tissue, both on the urethral plate side and the flap side, and this is why it is important to keep a good depth of tissue while elevating the flap from the underlying buccal fascia. A good depth of tissue permits subcuticular approximation, which may help in preventing fistulas. So the continuous part of the suture line is now almost at its end, but you can see that the right side lip of the meatus is still not as distal as the left side, and that is the space that will be completed by one or two interrupted sutures to bring the right edge of the meatus level with the left. It is also important while doing this sort of procedure to make sure that the meatus is of adequate caliber, which means that the total width of the urethral plate combined with the width of the overlying flap should be 1.5 times the diameter of the final meatus. In this case, we had a 4 mm wide flap and a 3 mm wide urethral plate. So together we got a 5 mm meatus in diameter. Having an adequate meatus is one of the major factors in prevention of fistula, because meatal stenosis leads to high pressure in the urethra distal to the repair. Now here we are mobilizing the thick subcutaneous tissue from underneath the skin in order to provide a vascular tissue layer over the suture line of the urethral plate. This prevents overlying of the suture lines of the skin closure and the urethral repair, and is another factor in the prevention of fistulas. The mobilized subcutaneous tissue is then sutured into position, covering over almost whole of the urethral repair. In this sort of operation, I suppose it is possible to expound on the intricacies of technique, but as we have seen here, you basically do the best you can with the tissue that is available. The foreskin is obviously absent and there is not much help in providing skin cover, but sufficiently mobilized, the skin of the penile shaft should be able to cover the urethral repair. It's a good principle to try and get vascularized tissue between the urethral suture line and the skin suture line so that they don't directly overlap each other. This is exactly what is being attempted here. Once the repair has been completed and just before the skin closure is a good time to tie the catheter in so that we don't lose it inadvertently in the subsequent manipulations. We have kept the same stent, 6 French infant feeding tube, in place that we have used for the whole repair. It is also, however, a good idea to replace this with a 6 French silicone stent or a Foley catheter draining into a Eurobag. Some people like to make the repairs over larger caliber tubes and then switch to narrower caliber drainage toward the end of the operation. It's just a personal view that it is better to retain the same tube that you've used for the repair to drain the bladder. The closure of the glands is now started, and just the one stitch is used to hold up the ventral lip of the urethral tube so that it doesn't recede into the depths of the glands. This is the only anchorage that it is going to get to the glands, because any further sutures will narrow the meatus and predispose to fistula formation. As you can see, the meatus has only been advanced to mid-glans position because attempts to take it to the very tip create more problems than they solve. So 3 interrupted stitches bring a sufficient amount of glans tissue proximal to the meatus to provide reasonable cosmesis, and the mobilized skin is now being sutured into place as the last stage of the operation. Finally, the incision at the Furlitz collar is closed and the repair is complete. Povidone iodine ointment followed by a non-adhesive dressing is applied and the catheter connected to a drainage bag. We kept the catheter in place for a period of 10 days, after which it was removed. The patient had developed a small coronal fistula and is presently awaiting closure of the fistula. Thank you.